So as I said, it runs in families. You have to treat the whole family. You have to change the kitchen habits of the house. It's just not possible to teach the kids. Kids are smarter. You can advise them, but if you don't practice it, the kids are not going to follow it. So I'm not going to details of the features of different syndromic obesity. There's a beautiful article in JCM I would like to highlight, published in 2017, how it helps us in evaluating the different causes. What are the histories we should take? History of neurosurgery, history of hypothalamic tumors, small history there. Head injury can be a very important point we should keep in mind while history and examination of a patient with pediatric obesity. Now, why is it important to manage childhood obesity? Because we know the end organ damage of childhood obesity. There's a high risk of diabetes, hypertension, dyslipidemia, metabolic dysfunction, associated fatty liver disease. The key point is the data shows that the burden of end organ damage and the progression of end organ damage is much more aggressive and faster in childhood obesity as compared to the burden or progression seen with adult obesity. So yes, all of these complications do occur, and they progress faster in untreated childhood obesity, and they are going to have a shorter lifespan and a more morbid lifespan, and it's really a sad story for the entire family, not only for the child. So yes, the cutoffs are also slightly different when we define that is important, especially when we look at dyslipidemia in children. The prevalence of MASLD is pretty high, just that because we are not looking for it. We should have a low threshold for screening for MASLD in children with obesity. So sleep apnea is also increasingly being reported, and all of these are reversible with good amount of weight loss. So I think the treatment should happen as a whole of the family and society at large. I'm not going to the details of diet and lifestyle changes. We all know that is important. But yes, when we look of childhood obesity, a few lines on obesity at an extreme young age of less than 2 years of age, it is uncommon. Only if there is a lack of breastfeeding, too much of top feeding, use of refined carbs, we are seeing it. So it is uncommon. And in this age, if you see severe obesity, you should again start looking for syndromic or any secondary endocrine causes for obesity. So the management is pretty similar. You preach what you practice, that is the way forward the entire family. Otherwise, it would be impossible to manage childhood obesity. With the use of food apps, online ordering of food, ordering food 24/7 has really made the worst in urban areas with regards to managing childhood obesity. I think indication of medical treatment is very clear. We would love all our kids to have their BMI down to less than 85th percentile. And if you look at medication, which was the topic for today's presentation, we don't have much of an options. Orlistat has been there, approved for use for a pretty long time now, but we know it is not a great, very potent anti-obesity agent. It has its share of mild side effects like flatulence, steatorrhea, but it has the best safety profile of all the available agents. Metformin we are using routinely in childhood obesity, specifically in pubertal girls with polycystic ovary syndrome. It really helps in taking care of different metabolic aspects, but we all know it's a mild weight loss agent. It's not a great weight loss agent. Phentermine not available in a country for use. It has been used in USA for up till 3 months of use is allowed. When you combine phentermine with topiramate, the quantum of weight loss is much more. Again approved for use only for short periods of time, not more than 3 months of use. Now what about GLP-1 receptor agonists, which is everywhere we see in social media, from medical literature to conferences? What about the use in children? This is a paper on use of liraglutide, with the high dose liraglutide. If you use in children above 12 years of age, they found that yes, there was around 5% reduction in BMI. So 5% reduction in BMI, not weight. That's a pretty impressive figure. But that's the high dose 3 milligram liraglutide done in primarily Caucasian population. We don't have Indian data, so perhaps we need to generate our own data, and my gut feeling is that perhaps we Indians have a smaller body habitus. We might do better even with lower doses of liraglutide. So this study led to the approval of use of liraglutide in obesity in adolescents more than 12 years of age. What about semaglutide, the more potent once-a-week injectable GLP-1 receptor agonist? There is no data on oral semaglutide. This is an injectable semaglutide. If you see here, the numbers are pretty staggering. Here we are talking of 16% reduction in BMI. That's again BMI, and nearly 73, virtually 7 out of 10 kids could achieve more than 5% body weight loss. So I think what the key point to remember is that the pharmacotherapy is not the gold mine, it is not the ultimate solution. These are short-term gaps for a better implementation of diet and lifestyle changes. So at least the child and the parents see some positive change, so they are further motivated to continue the diet and lifestyle change for a long period of time. If you are just on pharmacotherapy, sooner or later you are going to come back to square one. Because we are seeing with bariatric surgery also people losing weight, coming back, even overshooting even 5 years down the lane. That's not uncommon with bariatric surgery in adults. What about metformin we discussed, and of course for syndromic obesity we have specific drugs. We know the benefits of growth hormone in Prader-Willi syndrome. The setmelanotide, a specific agent, works great in MC4R receptor mutations. What about bariatric surgery? Yes, there is data. Typically its use is delayed unless the puberty is completed. The concerns with is the quantum of weight loss may have impact on the final height outcomes, the bone health outcomes in these kids. When we talk of bariatric surgery, primarily the malabsorptive procedures have been studied in adolescents and young adults, not the restrictive procedures, because the long-term side effects are much more with restrictive. Sorry, I'm saying the opposite. Primarily restrictive procedures have been tried and not the malabsorptive procedures, because malabsorptive procedures like RYGB surgery would have more potent weight loss and more longer metabolic effects. So sleeve gastrectomy is primarily which has been studied in children. So we published a systematic review on the outcomes of this metabolic surgeries, which is sleeve gastrectomy primarily in adolescents with severe obesity. Or these kids primarily, all of them had BMI more than 35 or 40 kilogram per meter square. Here if you see, an average, the mean reduction of body weight was only around 25 kilos in these kids, and the percentage reduction of BMI was around minus 24% reduction in BMI. And of course, with such greater amount of weight loss, you have an improvement virtually all the aspects of the comorbidities or end organ damage like fatty liver disease, dyslipidemia, dysglycemia, menstrual irregularities, PCOS, you get a benefit. So yes, the data, follow-up data is available only till 2 years. What about the long-term effects? We still don't know. These kids are being followed up. Again, if you can't sustain a good diet and lifestyle change, you are going to come back to square one. I would like to end my presentation by saying that childhood obesity is a really, really dangerous medical condition, and its impact would be even apparent 20, 30, 40 years down the lane, perhaps even for the next few generations also. Not to be ignored, treat the family as a whole. Unless the parents start losing weight, the kids are not going to lose weight. We should be role models for our kids and our neighbors and family members. Thank you so much.